we're doing a continuing education for lower body, which pairs with the one we did last month, upper body. So we're going to try to bring it all together. And we talked about implications and fitting all of this into practice and all that prior. So now we want to focus on the doing. And the main intervention, if this is indicated in these particular muscles, is inhibitory pressure. That's one. And then movement. And then to try to bring the idea of the upper body and lower body together. So, Fallon asked the question about how much pressure do you need? Now, obviously, this is too high, right, for the body mechanics. But if we're thinking of layer 1, layer 2, layer 3 here, a lot of the muscles we're going to try to address are deep. They're into like what's a layer 3, not all of them. And there's surrounding vulnerable areas, like there's a concentration of vessels or something in the area. Like if you're in the abdomen, you've got the descending aortas, and you know there's if you're like we had in the neck, we had all of the brachial plexus that comes out through that. So it's not any different than if you're working on more surface tissue like gastrocnemius. It's how do you get to the area safely so that it's getting enough stimulus to respond and reset. So the other thing that we want to try to avoid is real pinpoint pressure, which who's had trigger point? Who hadn't had a massage that had a lot of trigger point to it? Anybody? Seems like we talked about that. Yeah, it's a lot of with a tool, real pointed, or you know, with the point of your elbow or something like that. We want to avoid that. We want to have as big a contact as we can. So, what I want you to pay attention to, I'm going to start pressing here on the top. I want you to pay attention to distortion underneath here. Not what I'm doing up here, but did you see right there that you saw a change? Movement, yes. All right, so now obviously if I'm just doing surface, you're not going to get a translation of the force down through the layers. But you don't have to like dig and peel these layers away. You can affect them, like Luke said earlier. It's just about changing the shape or the movement of it. You also have to create a big enough sensation so that the body's paying attention to you and the person knows you're in the right spot. So if I start to press on this, already you should say changes happening in here. And then, since you asked the question, Fallon, why don't you come up here for a minute? Luke, you're taller. I'm going to have you apply the pressure.
But also think too, I'll show a couple versions. You're just going to put your hand underneath.
And when you feel the pressure, you say. Yes, I feel it.
So that could be increased as I. So it's a realization that you sometimes are very surface, or it can be I position in such a way where I'm pushing these and creating some friction or some stretch between the layers. So it can be pushing down if you feel. And then when I start making that green bolster slide, that's still shearing it off of the scrub top here, right? Both of which are the compression or the shear back and forth is making this unstuck from these surface things. And as you heard about a guarding pattern, where when things are really bad, if everything gets frozen, then maybe we just need to kind of compress it and unstick it. But we can be affecting these deeper structures if we're just tactful for thinking about what we're pushing through or what we're moving on top of it.
Okay? Does
Yeah.
that help understand that even though these tissues are down, we can affect them
Thank you, Kelly.
with pressure that is obviously applied to the surface. We can't take a knife and peel it off, right? And then the other thing that Luke mentioned is that all of these layers have a sliding component to it. When we ask the person to move, we are bringing in that translation, that back and forth. We're bringing in that friction. And
I
then,
hold this down, and then they move something around. And from a connective tissue standpoint or two layers, if this is stuck together like this, and I'm something that has just glued it down, and I apply some pressure to distort that, to put some stress on it, and the sensation that she was saying has to be big enough, because we're also talking to the nervous system. The sensation has to be big enough for it to really focus and go, I need to address or change something here. So I apply some kind of, it's stuck, but I stress it by maybe either using pressure or taking it in a particular direction. Now they move it back and forth. Let's say it's just shoulder movement or rolling their hips around. And as they move that back and forth, ideally, they pull all of that, and what I end up with is that being unstuck. I start here, and they pull those seams, and it ends up getting ironed out more smoothly. I visualize that a lot of. It's stuck folded, so if I just pin that and then have them move it, then I unstick that seam.
now that's not exactly what's happening.
No.
What's happening is that the amount of excursion between these layers is about like that. And there's a fibrous network in between there, like a crisscross. But it allows for this. And with lack of movement or a static position, or if there's been an injury or there's inflammation, that doesn't have as much slide to it. And that's when you start to get compensating movement patterns. That's when a trigger pointy thing, whatever they are, might start to set up. And a lot of what we do with the general massage is go with the grain across the grain, with the grain across the grain, and it's this kind of a thing that's going on. The other thing with lower body, as much with upper body, is bolstering and positioning in neutral. And this, and very important for low back, is that there is a pillow under the abdomen. You've got to get their spine
So,
in neutral.
Yeah. If they are laying like this, then their spine is at full extension, if not being forced into hyperextension if they have tissue in the front of their body that's going to force them into that position. So putting that pillow underneath and just a little bit below belly button level is what you're looking for, because we want to take their spine into a bit of trunk flexion. That's the ultimate goal. Relating a little bit what she was talking about with it not truly being about like unsticking a seam, it can be partly just lubricating fluid distribution.
Yes.
So if I have a pocket of tissue that has become immobilized, that means that fluid translation there also is limited. Lymphatic fluid movement, synovial for joints, hyaluronic acid for soft tissues. So if that's become just dehydrated, it's not quite the right term, but it's become thicker because it doesn't have as much of that movement, making it either be more liquid or the fluid isn't being dispersed in there between the layers, like WD-40 in a rusty hinge. That the pressure on it plus movement or working on things in a variety of directions helps either make things more fluid or it distributes the fluid. And it's So instead of it really being about unsticking layers, it can be, do I encourage those layers to be more slippery?
And cupping, it does an excellent job lifting the superficial tissue. And you're gonna get a little bit of movement into the deeper tissues. I would encourage you to feel comfortable with that as opposed to some of the harder to perform lifting, skin rolling, myofascial release type stuff, because it's harder on you, and you want to make sure that you're not hurting yourself. The other thing that would be an adjunct in any of these is taping. The other thing with these deeper type releases, almost all of them are most efficiently accessed sidelines. So let's position this character sideline.
This is where, in your routines, gotta just get out of prone faster is part of the story, right? Work a bit more surface in general here so you can just save that time. Then you get them on their side. One option can be to leave that pillow there, okay? Because if they scoot down, we take the bolster out, number one, take the bolster out. I'm gonna have the big square bolster come over in a second. If I have a person scoot down, now that pillow is positioned more on the thorax, up on the ribs. They turn on their side. I add a pillow.
I think he's got a broken neck.
Yes, he has a broken neck and a back. Everything's gotten more mobile over time. If anybody remembers this thing when it started, it's massage is working. It went from very hypomobile to now getting very hypermobile.
He wants to
No. But consider the pocket for the shoulder. Now, some people are perfectly fine without this. I have weird shoulders. I prefer this. So you can just leave that pillow there and then it acts as an additional cushion for sideline. You just leave it exactly where it is, make sure they scoot down. And then blammo. You got the next one. Position here. Look how neutral that spine is. Look how the shoulder isn't overly compressed, the neck's in line. Wow.
Now turn them over. Now the key is that bolster. So if you hear other people saying they don't like sideline or from other education or whatever it is, don't listen to them. They don't have that bolster. All right, and so that makes a huge difference in terms of stability.
I don't have new ones. I have a thing of foam, but if you guys need more, ultimately what you're looking for, the dimensions are, it needs to be pretty firm foam, it needs to be 6 inches thick, and about 8 to 9 inches wide. And you really probably want it more like this, like 2 feet long. You don't want, it's easier just with like tall people. I'd rather have the whole leg being able to be positioned like this, or like this, rather than having to move the bolster back and forth. I do that sometimes where I can just move the bolster a little bit like, but this dimension, so I think it's about 2 feet, but you need 6 inch wide and then, 8 to 9.
The other thing you can do is another pillow of some sort right here at the top. And where's the sheet? Because you know why the main reason why people don't do sideline is they don't know how to drape it. And it really is not that complicated on how to do that. All right.
Hold on.
I just need the gray sheet.
I know, there's another blanket stuck in there.
So, we can teach you all this stuff, but if you're not comfortable putting people in the position, you're not going to do it, right? So we got that. The client is draped. Now I like to have a big, full, flat sheet on the bottom. However, there's questions about that. because of laundry. I think we got this on wrong.
That's fine.
No, I need it this way long. There. So if Sandy Fritz had her way and laundry wasn't an issue, I would use this bottom sheet all the time to bring it up over, to help with the sense of confidence around the draping. But in a lot of environments or a lot of situations, you'll have just a finished sheet on the bottom and you have to figure out what you're gonna do with that.
Yeah, it's just saying, I mean, this is more for the video to see. If I uncover an area, being able to use this to come over.
So the big issue people have is exposure in the front. Can the camera see that?
We'll have to turn it around.
All right,
They
so,
say well
Stove
enough,
there
it's fine.
too helps that too. the color.
yeah, all right, so if you wanna come up and see what I'm doing from the back, what I'm doing is taking this, right? I'm gonna use that corner and I'm gonna use this corner. If you take this corner and bring it around under their head, make sure you squeeze their eyeballs out when you do it. All right? Okay? Then you can bring this over and the arm out. And there's a tightening that happens across the top. And then you're pretty much set. So
I tend to add one more thing. It's just, if you want, it's as opposed to having that additional sheet. But I did this too. Because of the arm being out and free and certain seams, especially like potential windows here, I was being overcautious. I just built into my routine this. And then I could do this. I could move this. I could move that. And the weight of the towel would help facilitate keeping that sheet in place. All right? So just, it doesn't even have to be that big of a towel, but being able to use this in such a way that even across the front of the body, I don't have to be touching the sheet and be making direct contact with the skin around this area, because I know that the sheet is pinned across the chest and under the head. But this extra little coverage, so that once I'm here, I can be holding onto this and moving it around to make sure I'm in the right position.
the rest of it's easy. You know, you just drape your corners like we've taught you before. That it's the idea of working around the chest, I think, that throws most people for sideline. So the bolstering and the draping is really, really important for you to feel confident with what you're doing. So all of these methods are also compression based, which means that you don't have to have skin. Unlike if we're doing a fluid movement kind of a thing or a connective tissue type of a thing, then you would need skin access in order to do it. These you can compress down, just like we showed you before, you can press down through loose clothing, for example. Typically though, however, we are going to be combining these things into massage. So you want to be able to know what you're going to do with that. So on a quick review, the positioning for sideline is where we can access the stuff. Let's roll him over again. Here's that stuff at the base of the skull that we worked on last time. Sternocleidomastoid comes right up into that, as does upper trapezius, and then second layer down, you've got your splenius capitis, splenius cervicis, that sort of stuff, and then way deep underneath there, you have your suboccipitals. So
Four of them on each side.
So when you are working with them, you want their nose down, right? Not that far down, but You want the nose turned towards the table. You want to concentrate what you're doing behind the sternocleidomastoid.
It should feel natural to do because if we're massaging from this position, if my direction of force tends to be up and across, then I'm gonna naturally kind of nudge their head in that direction. Does that make sense?
So, these tissues here respond to either compressive force with the palm of your hand or the soft part of your forearm. So if I'm just quickly reviewing these, this is that whole complex with the occipital, or the what am I thinking of? Frontal, occipital, not frontalis.
Occipital frontalis.
That.
Occipital frontalis.
Well, are you talking?
Yeah, right. The muscle right on the skull
Yeah.
is the occipital.
Occipitals, and then frontalis.
Yeah, and it's all
and they
one.
share your scalp as one tendon.
Yeah.
And then on either side of that, you got your temples, which I just assume is gallstuck. So you got a muscle on each side, a muscle on the front, a muscle on the back of the skull, not below the skull. The occipitals versus the suboccipitals.
And then these from the bottom weave up into that. So in this position, I can get a hold of all of that. Sternocleidomastoid, feel it on yourself, starts behind the ear, right, and is up high.
Isolating it is rotation plus flexion. It's the opposite way you rotate. If I rotate my neck to the right, then it's my left sternocleidomastoid that's shortening. So rotation, flexion.
And to make things easy is once I get something compressed, if you just move the area in a circle, just move an area in a circle. You can also just move the eyes in a circle. Or you can have the person look at it, look away. Look at it, look away. And the theory behind the use of the eyes is that your body anticipates the position of your eyes to where you're going to be moving. So if I'm looking left, everything that is going to take me left is going to shorten, and the other stuff is going to relax in an agonist-antagonist pattern.
Plus the righting reflexes at the base of the skull to try to get your eyes level with the horizon for appropriate balance and for your inner ear. So just using the eyes is a great tactic.
Working the skull, then on the skull and soft part of the arm, or with the palm of the hand, you can cup right into where the sternocleidomastoid is, and they don't have to have a real precise movement to it. You can do the circle. The next one would be suboccipital, and that one's where I'm going to cut their head off. Right, I want to feel the occipital base on my forearm. Head forward, coming down one side straight down, not at an angle. I'm going to have to come up now and come straight down. If you do it this way, you're only compressing one side at a time, and you don't have to worry about reducing blood flow to the brain, because the arteries that come up in through there, have you ever heard that thing if they lean backwards, like when you're getting a haircut or hair washed? Sometimes people will get dizzy. That's because you're cutting off blood flow. But if you do one side at a time, you don't have that.
And that pressure is going to naturally put people into flexion. So looking at the way she's finding this is bumping into the occipital bone, not pushing into it. It's not finding it and then pushing at an angle up. It's finding that and then going straight down, trying to be between the skull and C1, C2. You're not going to get that deep, but you want to bump into it and then go straight down.
You're going to have a similar approach when we get down here to quadratus lumborum. Okay, you turn and come in this way, and you've got scalenes. You can have them turn their head, move their shoulder, but the scalenes attached to the ribs, so you can also have them take a deep breath. So inhibitory pressure, if you go back just a little bit, you'll get another aspect if you go forward. And you're always trying to recreate the symptom. You don't just do this. You recreate, if they've got the pattern, it hurts into my side, my arm's bothering me, it's that spot behind my low back, or behind my scapula. Then I would go, is that it? Is that it? Oh, yeah, that's it.
Now her angle is closer to the shoulder or C7 shoulder growth. It's not high up, right? The scalenes attach on the lower cervical vertebrae. They go from the lower cervical vertebrae to the top ribs. So you have to be down here. Can't be on the side and up here. You gotta be down here for scalenes. And all of you can feel them if you find your own upper trap. Find upper trap first, which is right on top. Come a bit anterior. You should feel like something that's kind of ropey, little ropey things in there. Now take a really big inhale. At the top of the inhale, you should feel those shorten in there. Now that's not what people should be breathing with too much. That's where getting stuck like this can cause the scalenes to be chronically short. So using breath, one, you can use it as a muscle test by having them take a really big inhale. If you feel those kick on, you know you're on the right thing. But then it can just be, now focus more on the exhale is what I tell them. Hold the pressure and then use breathing instead of an MAT.
You can incorporate muscle energy technique where you deliberately have them contract, relax, antagonist, contract. Moving it in a circle is doing that. So, okay. From there, in the sideline position, if they're rolled forward just a little bit, and you apply pressure here, you're on latissimus. And that would be, what it does is internally rotates and pulls the arm down. So the opposite is up, but you get that when you roll it in a circle. And if you roll them, so behind the seam is latissimus. If you roll them forward, it's anterior serratus. Anterior serratus. So what does anterior serratus do? Well, it stabilizes the scapula. It's about the scapula. So, but if I roll my shoulder around big enough, not this, that's just the shoulder joint. If I roll it big enough so that the scapula moves, I'm going to affect anterior serratus.
And that's what you have to coach the clients to do. Big enough to move the scapula.
Or you have them reach for the wall. But that's a big deal. This, the latissimus dorsi, the pecs in the front, anterior serratus to a lesser extent on the opposite side are paired with the adductors. So let's say somebody is real sensitive in here and I can't touch that up here on the lat and all that. I can have them move their arm around, but I can apply my pressure down here on the adductors. That's where you start to get this back and forth upper body, lower body relationship. I don't think I did quadratus with you guys last time. No, all right. So, where did we stop? What were the other ones that we did?
Did you do subscap?
Yeah.
We did subscap.
Yeah,
Pec minor and subscap?
Yeah. Now you can get those in multiple directions, but it's easier to show that on the table if you need a reminder on that. Pec minor is not so hard. It's right in this little gap You know, you feel your shoulder, you come across, and it's
Either bring up a picture one of these days if anybody's looking at it in the video, but gotta just visualize that coracoid process. See that weird thing? That weird little hook? That thing goes from there, pecmine goes from there, splays out, and attaches onto the ribs.
and it does this kind of an action. It's
So
really
look,
a stabilizer. It's along with anterior serratus and all of that.
but look where it is, so using the scapula as a reference point, find the acromion. You can always find the acromion, right? And then approximate where the coracoid process would be in relationship to that. Be just inferior medial. And in order to be on the belly of pec, I have to be a little bit more inferior medial. I want to be between coracoid process and the ribs. I can use acromion, curl over, and then basically I use that as my starting point, and then I apply pressure and go towards the ribs.